to present Dr. Bertram Unger. Dr. Unger did both his undergraduate and medical training in Manitoba, at the University of Manitoba. And then in 2008, he received his PhD from Carnegie Mellon University, and then did a postdoctoral fellowship at the University of Pittsburgh. And then he came back up to Winnipeg, where he is now, I should point out, working as a clinician in the Department of Internal Medicine. But he is also the director of the university's the director of the laboratory, for surgical modeling, simulation, and robotics, and the research director of the university's clinical learning and simulation facility. And also he's a core member in the biomedical engineering graduate program. So very pleased to present Dr. Unger. Please give him a warm welcome.
Thanks. I'm having a little technical difficulty between computers here, so I'm going to still run my talk off of the other computer. I'll have to bear with me. Some of the videos are going to be a little slow. I'm working together with other people, Dr. Jordan Hoffman from the Department of Internal Medicine, Department of ENT Surgery, and Aaron Safari from here from Mechanical Engineering, had a lot to do with this research. And my primary research interests lie in teaching medical students, medical graduates, and other medical professionals skills using technology. So I'm interested in haptics and robots and medical displays and all sorts of other interesting things. I'm going to talk to you today about hardware versus software. It's a problem that we have in ENT surgery. We want to develop a temporal bone surgical model. And I'm going to talk about some different ways that can be done, some approaches we've taken in our lab, and some testing we've done on those approaches with the ENT surgery residents. I should first disclose that I hold shares in a startup company that's based on a patent application we're making. None of this research is commercially funded, though. It's just a spin-off from this research. There are a lot of people involved in this project over the last few years, including several master's students, some undergraduates. Dr. Jake Krause did a lot of programming. You can see here was a research fellow with us. And then a number of surgical residents and trainees. And Dr. Sinkowski from Materials Engineering and Aaron Safari from Mechanical Engineering here. And grant monies come from a variety of places as well. So that's kind of the housekeeping stuff on the way. I'm going to talk about surgical skills training, how we train surgeons currently, how we can do it better. I'm going to talk then about our own simulation design testing, in particular temporal bone models. I'll talk a bit more about temporal bone for those who might not know what that is. And then I'm going to talk about our haptic model, a rapid prototype model that we've developed, and finally a mixed reality sort of augmented reality model that we're working on. So when it comes to surgical training these days, we're still using a paradigm that was started back in the late 1800s. And it's basically an apprenticeship model. Students work under a trained surgeon and they're slowly given more and more responsibility as they progress in their training. But oftentimes it boils down to something we call see one, do one, teach one, which is a mantra in surgery at least. And as you can imagine, that's not really the best way to train residents, because the first time they're seeing one, the second time they're actually going to be performing the procedure, and the third time they're teaching it to somebody who's never seen it before. So, and believe me, that's the way I trained on a number of things. So you may hear that on Grey's Anatomy, whatever current medical program you watch, but people actually do that. There's a new emphasis on training residents and medical students with simulation in an effort to improve patient safety and expose them to more interesting things. And one thing is we're reducing the amount of hours that the residents are working. Another mantra that the surgeons often have is that what's wrong with being on call every third day? I mean, that's 2/3 of the interesting cases. So there isn't as much time as they would like to see the interesting cases. there's limited operating room time, and patient safety has become a huge issue in the last 5 to 10 years. There's a study in the late 2000s about medical errors in the U.S. They found that there were up to 100,000 deaths per year due to medical errors in the U.S. I don't actually really believe those numbers, but certainly there's a significant number of deaths due to medical error. We can reduce that using simulation, I think. Simulation lets us have residents rehearse their skills before they actually have to go and work on a real patient. And it also allows us to objectively verify that they have achieved the skill level that they're supposed to. And we're trying to train people now to a certain skill level rather than just get them to do a certain number of cases. We can repeat the same procedure over and over again until they get it right, basically, on the same exact setting. It saves operating room time, it improves patient safety, and it reduces the morbidity. Those have all been shown in studies to be the case. So that said, there's clearly a need for simulation. I'm interested in simulating surgical skills. And the question that we ask ourselves in simulating skills is what's more important when you're simulating a skill? Do you want to simulate the visual component of it? A lot of what we do is related to vision. Do you want to simulate the touch component? That seems to be very important in surgery. There's some research in the haptics community that shows that when you're doing a task, you tend to rely on the sense that's the most reliable. And so if you degrade the sense of vision, so you're operating deep inside the patient's abdomen, then they're going to rely on the sense of touch. If you're operating somewhere where you can see everything clearly or can only see something through a laparoscope, for example, then you rely on your sense of vision. For certain procedures, you need to have both visual and haptic surgical simulation. The temple bone is sort of the example that we're going to talk about today, and that's because the ENT surgery people came to me and said we want to build a temple bone simulator. The reason they want to simulate this part of the anatomy is it's very, very complicated. The temple bone is this area on the side of your head that sort of surrounds your ear. It's the stuff that wanders there on the skull. And it's a close-up view of that shows, and a cutaway view shows that there's lots of important territory in there. There's the inner ear structures. There's your facial nerve, which controls the motion of your face. There's the jugular vein and the carotid artery run through that location as well. Something called the sigmoid sinus, is just a continuation of the jugular vein. And the brain lies right next to that part of the bone as well. On top of that, it's very variable. Lots of people have different anatomy in that area. There are all these little air cells in that region as well. And those are different for almost everybody. So we've got a very variable, very three-dimensional place where people actually operate. There's my trouble with my slides. So you're operating in a small area. Usually this is called a mastodectomy procedure. It's going to run. Basically they cut the skin away and then they drill in there with it's called a surgical drill. It's basically the same as a dental drill. But you have to be careful not to nick any of those structures, because if you nick the jugular vein and the carotid artery, you have massive bleeding immediately. If you nick the brain, it's obviously a bad thing. If you nick the inner ear structures, you may have your ear again. If you hit the facial nerve, which runs right through the middle of that, the side of your face can be paralyzed for life. And that means you're drooling and you can't smile appropriately, a lot of things like that that are quite important to people. So it's a very delicate, complicated surgery done with a drill, most of it, and with lots of stuff at stake. So there have been a number of attempts to simulate this area in the past, and currently the way the residents train is in the operating room. If they're going to operate, if they're going to practice outside of the operating room, they work with cadaveric bones. So that's the gold standard right now. People donate their bodies to science. The top picture there shows the temporal bones we cut away from the body. Our residents in the ET program practice on 1 to 2 temporal bones a year, each resident. So that's like they get 1 procedure per year on a temporal bone outside the operating room. Sometimes they go away for courses and do a few more than that, but mostly at our institutions once a year. That's motivated a number of attempts to build a haptic model. How many of you are familiar with haptics? We're going to cover a little bit more depth shortly, but when I say the word haptic, does everybody know what I mean? Basically, it's using a robot arm to provide a virtual sense of touch. So when you're operating in a virtual environment, you're drilling away at a virtual temporal bone. You can imagine you're holding a joystick and playing with this thing graphically, but the joystick actually feeds back a sense of touch to you as well. And the goal there is to give you a sense of where the drill is and what's happening. So there have been a number of different models developed for that outside of our institution. We developed our own as well. But a lot of surgeons complain that it doesn't feel very good. The sensation of drilling, which is important to the surgery, doesn't feel accurate with a haptic model. So there have been a few attempts recently, because 3D printing has gotten to be fairly inexpensive, at building a 3D printed or rapid prototyped model. What we were interested in doing was building a better rapid prototype and then comparing it to haptics and seeing which one was better. So if you're going to compare simulations, what's the best way to do that? There are a number of sort of standardized ways. Some of these are starting to fall out of favor, but this is sort of the standard things you'll see in the literature. People do subjective tests where people are just asked whether they like the device. So you get a bunch of surgeons and ask them if they feel this is a good tool or not. And content validity, which asks, does the content reflect what we're trying to teach? And there are objective validation tests in which we test for construct, where we ask if the simulation can tell, if we measure the simulation, we can tell the difference between a novice and an expert on the simulation. And also concurrent validation, where we ask, does the performance in the simulation mirror real life, and does it make a person better in real life at their procedure? So for our testing so far, we've really only looked at the first two steps of phase of content validation, and that's what I'm going to talk about a bit more today. So the project that we came up with and sort of been working on the last 2 or 3 years was to design a haptic model and a printed bone model, and then run validation experiments comparing both haptic and printed to cadaveric bone, because that's the gold standard, and then finally comparing them directly to each other. The actual study involves taking micro CTs of the cadaveric bone at about a 35 micron level. That gives us very high resolution quality. And then doing segmentation of that bone material. I'll talk a little bit about segmentation later on. Basically, we're splitting the bone into hard tissue, bone, soft tissue, such as the various vessels and structures inside the tissue, and then creating separate models of those, which can then be recombined into a model that can be colored differently, so we can color the blood vessels differently from the bone, etc. And what this effectively does is it lets us build from the same 3D model. We can build a haptic simulation as well as a rapid prototype simulation. And so residents are able to drill a cadaveric bone and then drill exactly the same anatomically identical haptic bone, and then drill exactly the same anatomically identical rapid prototype. So we've got 3 bones, but they're all anatomically identical. So the first study we did, we looked at haptics versus the cadaveric procedure. And haptics is, as I said, giving a user a sense of touch using a computer interface. Effectively, we use a robot that has force feedback system. And we have to, when you bang into something with the robot arm, effectively we turn on some motors to break the arm. Put the brakes on the arm so that you feel like you're pushing on a solid object. You can imagine there's a pretty complicated control problem involved with that. There's a basic force feedback haptic model where you have a human that applies forces to the device mass, and a virtual world that's also applying forces to that device. The position of the device is modified by the human and transmitted to the system. And depending on how you set up your control, you can use either force control or position control to control the system. Most of the haptic systems out there, not all of them, but most of them, involve linkages, robot linkages that are activated by backdraftable brushless DC motors. The reason backdraftable is so that you can actually push them back against the force they're producing. the machine inputs energy into the system, the user inputs energy into the system, and this can result in an unstable condition because the machine can actually generate energy, and if the control runs out of control, the device can oscillate rather horribly and very unstable. So it can produce significant vibrations that you don't want to have or large impulse pulses. And the other problem with haptics is that typically the devices aren't very stiff. Those background motors can't produce a super stiff surface, at least not at the sizes we want to use in that. And so you can't really produce a very stiff surface like roll, for example. The simulation that we developed used a phantom omni. It's a fairly common haptic system. You can probably see some around here. I think Zara has a couple. And it's a 3 degree of freedom system. It's activated with 3 degrees of freedom. That is X, Y, Z are activated. And it can sense 6 degrees of freedom, so it can sense the rotations. We use a set of stereo glasses, a big plasma TV, and an on-off the pedal to drive the drill, the virtual drill, and it was all done with an NVIDIA 3D kit. And this is the graphics basically for the haptic system. I don't have the haptic system with me, but it's a demonstration of what the bone looks like. And basically the model that we work with is a voxelator model. There's several million voxels in this model. And you can drill them away with the drill. The process of rendering the voxels and drilling them away is fairly computationally intensive, so we actually split the model into pieces using an octree, and then we do multi-core processing to try to reduce the computation. The system then uses, we want to present the user not with a voxelated model to look at one nice smooth model, so we actually use Marching Cube's algorithm to convert things to a mesh, and then do Laplacian smoothing on the mesh to get a nice smooth looking model. It's basically Minecraft with Temporal. For the haptic algorithms, typical haptic algorithm uses a virtual spring technique where, especially for a voxel model, there are a bunch of springs that are, virtual springs that are imagined between the sphere that's the tip of the drill and the actual model. And the forces are based on the springs and how they contact the sphere. We found that resulted in a tendency for the drill to lock up. If you went underneath something, it got stuck underneath it or in very tight spaces. So we switched over to something called a sliding position locking technique, basically where the drill is constrained to move along the surface based on a predicted desired position. And this just demonstrates that we can get into the fine details of the model and not lock up. A lot of there are several other haptic models out there, and some of them have a tendency to lock up when you get into small spaces. The whole thing is based on STL files, and we can switch easily between models. And the STL file is a standard file that's used in a lot of 3D printers and a lot of computer graphics, and it lets us easily move between different simulations. The system was designed with education in mind, so we can do things. We can make various structures transparent and change the level of transparency so you can see what's inside the bone before you get there. Which of course you can't do in real life, but it helps people learn the anatomy. This is an example of the ability to basically record the entire procedure and let people, if you make a mistake, you can back up and try again with all the procedure. So it records all the changes that are made, back up, straight to the procedure again if you need to. And we also have the capability of then recording what an expert does. So we have somebody who knows what they're doing, drill out mastoidectomy, and the device will then replay that, those hand motions, and someone can put their hand on the device and feel what's happening. Another way of using that is to actually record all the forces involved as well. And we can actually display the desired forces and where you are and where you should be based on the experts' hand motions. So that's the haptic model that we designed in our system. There are several others out there. One of the reasons we built our own was we wanted to test ours versus cadaveric models and also versus our printed bone. And it's hard to get somebody else to put their stuff up against other modalities and go head to head. So that was one of the issues we had. And also some NDA legal agreements stuff that we had trouble. That's a whole other ball of wax that you might run into as a researcher. But we built our own system so we can test against cadaveric and typical printed stuff. The study itself involved 10 different specimens. That was basically all the specimens we could get in 1 year. We had 10 residents, so each resident got assigned one cadaveric sample. We segmented the data semi-manually, so I'll talk a little more about segmentation a little bit, but an expert had to segment each of the bones. And then integrated those into our virtual model, and then had the residents dissect first a cadaveric bone and then a virtual simulation. So they did one cadaveric bone and then they identically matching haptic simulation for that. And then they rated those simulations based on basically the physical characteristics of the simulation, hardness of the bone, how things sounded, the vibrational field. They looked at how it represented specific anatomical features, rated how they thought the device would be useful for various surgical skills that they were supposed to acquire, and finally sort of gave us an overall view of their educational level. And this is some of the data. So they were measuring these things on a rating scale from 0 to 7, where 7 was very similar to cadaveric bone, and 1 was very dissimilar, 1 to 7 was. And as you can see, the marks weren't very high, generally speaking, for the physical properties. Most of those aren't getting a passing mark in terms of how they felt as compared to the cadaveric bone. We look at how they felt the system represented the anatomy of the bone compared to the cadaveric specimen. It did much better there. Most of them think it represents the cadaveric anatomy pretty well for a lot of different parts of the anatomy. And generally for surgical skill acquisition, they rated it kind of middling, sort of 4s to 5s in terms of how effective they thought it would be for helping them learn various procedures. And overall educational value generally got sort of the same sort of scoring. Now the interesting thing here though is when you ask them, do you think this should replace the cadaveric lab? None of them thought so. They all hated it. So clearly we don't have something that's going to replace cadaveric specimens as a teaching tool. It might be a good adjunct. Just looking at some of the ways we want to take this system, I want to develop this into a full 6-degree freedom activated system. We're looking at doing a large multi-center trial to validate the haptic system. We want to look at our metric tools to see how effectively they measure things. And this is a fluid modeling simulation that we're developing for simulating bleeding on the model, which is not yet ready for prime time. And finally, we want to validate those teaching tools. So, concluding about the haptics, so there's more to come. The haptics, we generated a stable haptic simulation, had excellent graphical reproduction of the anatomy according to residents, but we're limited by the device's 6 Newton force maximum, which is it's not a lot of force. We can't render a stiff bone interface, and that was what most of the residents complained about. Clearly it can be useful for teaching surgical approaches in anatomy, but not really good for teaching drilling technique. And This was probably the first study that's been done where we actually compared isomorphic or identical cadaveric to haptic samples. So a solution to some of those problems is 3D printed models. And again, the reason for developing 3D printed models is pretty much the same as developing haptic ones. It's hard to find cadaveric specimens, and the haptic models are limited by stiffness. And we can do the same things with these models as we can with the haptic models. We can measure how people do on them. We can change difficulties. We can present them with a lot of different cases. And we can standardize how the trainings are taught. Another thing that we can do actually with both systems is to do pre-op surgical rehearsal. So if we have a difficult case, a surgeon can come in and we can set it up on the simulator for them to practice on before they actually go to the operation. There have been a couple of other groups working on this kind of stuff. And as far back as 1998, and possibly further back than that, there have been people that did stereolithography for temporal bone surgical practice, but back in the 1990s, 1980s, stereolithography was very, very expensive. A model could cost you $2,000 to $5,000 just to generate one model, so drilling it away didn't seem like a good option. It was occasionally done for pre-operative rehearsal in difficult cases. There's a group in the United Kingdom which has its own unique problems with getting cadaveric samples. They can't use cadaveric material in the United Kingdom for training purposes due to a recent law about 10 years ago. And so there's a group in the United Kingdom headed by Pettigrew, basically build these urethane plastic models and craft them in their basement. I suspect we ordered a model from it sort of came boxed up and looked like it came from somebody's home. And that's what it looks like. Which is, you know, it's a way of learning certain critical procedures, but doesn't represent the anatomy very effectively. There's a group in Japan as well that's used laser-sintered acrylic, and we've gotten a fairly nice result there, but the laser-sintered acrylic doesn't drill very well. Acrylic tends to burn when you drill with a high-speed drill, and when you burn acrylic, I believe you get cyanide coming off, which is not a good thing. They've also had trouble with getting the anatomy and the internal structures right, which is one of the problems with all of these things. The internal structures aren't quite right. Dr. Hockman had actually worked a little bit in Toronto on 3D printing temporal bones using a powder-based printer and had a fairly good result. The only problem is that when you use a powder-based printer, the powder is used as a support structure. It kills all the internal cavities. So again, the internal constructs don't drill the way they really ought to. So we look for a way to eliminate the internal powder and create those internal void spaces that are there when you drill the bone. So the design again starts with a CT scan of a cadaveric bone with 35 micron resolution. If we want to do this clinically, the resolution is much worse. It's about 6 millimeters, but it can be done. The problem is segmenting out the finer structures of facial nerves, not very wide. So you have to have either a very good guesser or some semi-automated statistical method for finding the internal structures. So there has to be an expert involved in the segmentation, which I'm going to show you next. And segmentation of the bone is based on looking at the Hounsfield units in the CT scan. So the CT scan has is based on density of the material that the X-rays are going through. We can basically bin the voxels by density and just select those voxels that fit the appropriate density. So that works well for bone. It doesn't work so well for soft tissue. Soft tissue, we pretty much need an expert to tell us what we're looking at because the density can be the same between two pixels that are in different structures. And so you have to have some anatomical knowledge. So we generate, from the CT scan, we generate a set of polygon mesh models, STL models, which are then reconverted back into voxelated format. And then we have this in-house software we designed which allows us to slice that temporal bone into various pieces. And basically, we cut the bone into user-defined planes so that we can blow the dust out of each piece. And we put alignment crucials on each piece in an appropriate spot, a male and a female piece, so that we can snap them together at the final end, and once again coat the whole thing ultimately in cyanoacrylate. Here's the printing process. Oops, that's not the printing process. Oops. So that's a description of how we convert the voxelated slices back and forth. Polygon mesh voxels back to polygons again in 3D printing. It's similar to a marching cubes element. Here's the 3D printing. It's time-lapse photography. Watching this is kind of like watching paint dry, and Davis has speeded up about 100 times. Should probably update that. I'm going to just, I have two models here. I'm going to pass them around. One has the mastoidectomy procedure done on the right, and the other one is one with fiducials on it. The 3D printing is done on a proprietary Z650 printer, and it can print color. And the material that it prints, we selected it because we didn't want to work with plastic. It doesn't drill well. We wanted a powder-like material that would be similar to bone. This stuff met our requirements most closely with anything you can find out there. So just to confirm that we had a material that was bone-like, we did some mechanical property testing on it. Basically took some lamb cortical bone and compared that to a model of that bone. And looked at stress and strain in those materials. And you can see there that depending on the infiltrant used, we use a hardening agent to harden the print after it's printed. Based on the material that's being used as an infiltrant, some of them resemble cortical sheet bone, stress and strain curve better than others. They all fit relatively well. If you look at rupture forces and the elastic modulus, again, there's some variation. The bone, the property, the material that we chose ultimately was cyanoacrylate, mainly because it matched fairly well for everything except for the rupture force, and tended to be on subjective analysis by the surgeons seemed to be the one that felt best. And finally, it's the least toxic of the various treatments other than saline, which generally didn't match the bone at all. So it was easiest to apply. So there you see the stack of slices that goes into making one of these things. You can slice the bone any way you want with our slice program, and the idea there is to cut through the plane so you can actually blow all the dust out and reassemble it intelligently. We use like a peg and hole fiducial to align the pieces, and it works relatively well. And that's the final product, which you're probably passing around right now. And here's a surgeon drilling a mastoidectomy procedure on the bone. You can see that their hair cells are in there and they're open, which is different than that earlier example we had. And that makes a big difference in the feel of the bone, because if you're drilling with a drill and you hit a pocket, you have to know how to hold your hand steady and not punch through and cut into something that you shouldn't. We did a couple other sanity checks. We CT'd the printed model and compared that to our original micro-CT of the cadaveric bone. And then we looked, this is basically an inverse of the two CT scans, looking at the air cell spaces in the map. There's a pretty good match there. You can see visually, and it's 88% when you look at the statistical match between the two volumes. So we did effectively the same series of tests. With cadaveric and printed bones. Again, with 10 residents, they drilled an exact replica again of temple bone, the cadaveric bone that they were drilling. And again, looked at the same properties. And this, just for comparison, is the earlier Haptic study that's in green versus the round prototype in yellow. And you can see that generally speaking for the physical properties, now the residents are liking this much better than they like the haptic model. It's still not meeting, we're not getting 7s across the board, but it's much closer to the cadaveric model than the haptic model. And we only had 10 subjects, so statistical significance was hard to achieve on some of these things, but we do have several that are significant, in particular the hardness of the bone and the vibration of the drill and the skipping drill, which are key ingredients in performing the procedure. Those were felt to be significantly better in the rapid prototype. When we look at the anatomical representation, there's no statistical difference between the two sets of data. The trend, obviously, is that the printed material is slightly better representation. They scored higher on it in every category, but there's no real significant difference between the two. So clearly, for anatomical representation, we can use one or the other. When we looked at surgical procedures and training, again, there's a trend towards everybody liking the printed bone better for learning various surgical procedures. We only had significance in the mastectomy and facial recess procedures. Of interest, though, those are the two most common procedures that are done by the residents. A significant number of our residents may not have done some of the other procedures, so I think if we had a larger sample or more educated group of residents, we basically went from R1 through R5, so the range of training was from the first year to 5th year residents. If everybody had been a 5th year resident, we might have seen a better statistical outcome of that. Needless to say, the common procedures were statistically felt to be more trainable with this model. And in overall educational value, again, you see a trend towards preferring the printed model, and that carries through with the other examples I showed. We asked them to directly compare the two and say which one they preferred for a variety of different things. And here, in a direct hand comparison, the haptic simulation is not considered good, nearly as good as the printed model. Almost everybody selected the printed model as better in every category. The only categories where the haptic simulation seems to perform a little better are in visual or in ease of use. The haptic system is easy to use. You just sit down and play with it. The temporal bone, you have to set it up and there's dust and all vacuuming and things like that. So it's not terribly surprising that those two are rated higher than haptics. So just to conclude and sort of sum that up, the printed bone seems to be preferable across pretty much all the domains. The haptic system seems to be considered good for anatomy and potentially for learning surgical approaches. Generally speaking, the virtual system is easy to use and has a relatively nominal expense once you bought the initial hardware and software setup. Whereas these models, you have to print them again and again. And the cost is, well, fairly inexpensive. Excuse me, fairly inexpensive. It's not completely inconsequential. In fact, it's about $100 to $150 a that price may well come down as printers become more. Future directions for the printed models, we're slowly generating a library of these cadaveric specimens for training purposes. We're developing some assessment tools. We're developing something called a chimeric model where we're injecting soft tissue into the soft tissue, latex into the soft structures, to simulate soft structures, as well as putting electrically conductive material in some of them so that we can tell when you actually contact the facial nerve, for example. We're putting this into the educational curriculum hopefully this year, and looking at using it for pre-op planning for complicated surgeries. The spinal surgeons and the orthopedic surgeons are also quite interested in working with us. We've done some work in Calgary on spinal surgery, and the orthopedic surgeons are also thinking about using it. And finally, we're trying to combine this together with the haptic system to try to get the best of both worlds, something we're going to call mixed reality simulation. So that's something that's a work in progress. I'm going to sort of wrap things up and talk about that a little bit. The printed models are relatively expensive. They don't represent the soft tissues particularly well. They create some dust during dissection. But they have very realistic drilling characteristics, and that's what surgeons really like about them. The haptic models don't have good drilling characteristics, but they're good. You can manipulate soft tissue models fairly easily, and you can easily reconfigure haptic models. So we thought we could bring them together and get the best of both worlds. If we would lay the virtual model, haptic model, over top of the printed bone model, so basically you think this is augmented reality, but not haptics rather than visual augmented reality. This would give us the ability to be able to really feel where the drill is, allow us to reconfigure the soft tissue quite easily, and it would allow us also to measure what people were doing during the procedures. And so what we did is we wanted to attach the surgical drill as an initial landing of the haptic system, so that you see here in the corner here, this is a surgical drill that's being attached to this larger HD² haptic system as the joystick, the thing that you interact with. And so you can imagine this drill going through this block of material here. First it hits real material, drills through real material, gets into the middle space, which is then filled with soft tissue model, virtual soft tissue model. So at that point we switch the haptic device on, and you feel the resistance of soft tissue. When you hit this layer, you're again drilling real bone, and then you hit this layer and you're in free space again. So you're switching from a real environment to a virtual environment, back and forth. And you can imagine that there's some interesting problems associated with passing from a real to a virtual environment like that, particularly in boundary conditions. So the mixed reality design, we've basically achieved the first 6 steps. We're still working on step number 7. Starts with the same segmented anatomy, graphical interface, some soft tissue models. We've developed some rudimentary ones. We need to work a little more on that. We have a fairly good working rapid prototype model right now, and we mixed the drill and the haptic system together, and we've achieved registration between the physical model and the haptic model, which is a fairly significant problem as well. And we're still working on the force feedback interaction. So we used a different haptic system for this model, basically because the phantom can't produce continuous high forces. It needs to be able to hold that drill up, and the HD² was able to generate a higher force, a continuous force. It can also produce a higher stiffness, so we can have a wider range of models. It can produce significant torques, and it was fairly easy to modify. We integrated a Medtronic's drill into the haptic system. That was, we basically took the haptic device. The way you work with this haptic device is you grab this wand in between here and you move it around in space. And we basically wanted to switch that wand out for the surgical drill. So we had to build a little holder that held the device in place. And you can see this one. Basically, you see that the drill is held by the holder, and someone can hold the drill and drill it as if they're using a surgical drill, but it's attached to the haptic device, so we can apply forces to the drill, external virtual forces to the drill. We had to modify the balancing system and control system for the drill. This worked out well for our master students. And we had to correct some of the mathematics of the way the coupling forces worked. We wanted to change the interaction point. The interaction point is the point in the real world that interacts with the virtual environment. We had to change that from the middle of that wand down to the tip of the drill. And we wanted to compensate for the weight of the holder that holds the drill in place. So basically gravity control. So the force of the drill tip was simulated by a force and a couple moment around the center of the default handle using these equations. And we also built some equations that would cancel gravity when that additional weight of that drill was attached. You can see this person's manipulating the system. And it stays where it's supposed to be as if there was no weight on it. As I said, we get into some interesting situations when the device moves between real and virtual environments, or if there's any sort of error in the force calculations. And then you have this stability that can occur as the tip goes. If you can imagine going from the real environment to the virtual one, the virtual one provides a force that tries to push you back with you now into the soft tissue. And if you're right at the boundary layer between the two, it pushes you back into the real environment, at which point the system cuts out and the control model quits. But now you're pushing back into it again, so you get this vibrational state at the boundary, and that can become rapidly unstable. Our simplest solution so far is just to put a low-pass filter in there and eliminate the rapid oscillations, but we're still looking at more complicated ways of having that instability boundary stability. We integrated Medtronic drill straight into the Haptic system so that we can actually read the state of the actual drill and reflect that to the virtual system. Here you can see the system in action. So this person's manipulating the drill, and you can see the drill in the virtual environment is moving around in space. Foot pedal can be used to drive the drill. It sounds a lot like that. That's roughly where we are currently. We've also integrated the bone into the system in order for the virtual system to work together with the real system. It has to know where the real bone is in space. And to do that, we simply put some fiducial markers on the bone, touch the fiducial markers, with the tip of the drill and tell it which fiducial marker you're touching, and then the system basically uses some math to calculate where the bone is in space. And that works pretty well. Of course, if you move the bone, then we have a problem as a re-register. So we're looking at ways of trying to continuously track the bone and know where it's in space after first registration. That's a work in progress too. So I think there's a promise of using mixed reality for getting the best of both worlds, letting you simulate soft tissue. We can also simulate bleeding, changes in friction, and other aspects of surgery with this that we can't just simulate with a simple bone, 3D printed bone. And still give surgeons that the real drilling field that they're looking for when they're in training. As I said, we want to do some curriculum integration of the bone itself. We want to formally evaluate how this affects people's training. We want to look at developing some more metrics, ways of measuring how people are doing things. Recently, got some head-mounted graphics display equipment. We want to be able to throw graphics on top of the bone at the same time as you're drilling as well, and expand things to other surgical skill sets. That's talk.
We have a few minutes for questions if anybody has them.
Well, thank you, Bertram, for such an interesting talk, actually. The thing that really was in my mind as you were speaking is when people are using cadavers versus the real thing, how different is that? Because it's almost like the comparison is with, you know, cadavers, and it might be quite, your system could be really closer to the reality.
That's probably true. I mean, the cadaveric specimens are definitely not the same as the real.
I wouldn't be surprised.
Yeah. They've been processed with, I'm not sure what they use, Temporal or something at this point, these different things. But, and I know that they do some training, some places do training on fresh frozen cadavers. So basically it's like a dead body that hasn't had any treatment. But the treatment itself changes the way the bone feels. And obviously you don't have bleeding, you don't have a lot of other things. So potentially you could make your system more realistic than the cadaveric training that they currently do. I don't think we're really close to that yet. The cadaveric training is sort of well accepted and as the gold standard. And we'd have to get into the operating room and measure what they were doing in the operating room and measure a lot of parameters in order to incorporate those into our system. that in itself is hard to do, hard to understand that. And it probably requires to build a whole new set of tools to do that as well. So I don't think we're close to doing that, but potentially, yes, we could make a system that was more realistic than the cadaveric system. And we can make certain parts of the system more realistic right now. We can add bleeding, for example, in a virtual haptic model that you can't really reproduce in a cadaveric. Yes.
First of all, thanks for sharing such a good presentation. I have one particular question in terms of on slide 47. You're presenting cooperation between a printed model and then that same printed model rescan and how it compared. So you were showing up a percentage of 88%.
Oh,
It was
was that the air cells slide? Oh, this one.
that one.
This
yeah,
one here?
Thanks so much. So if I'm correct, you rescan the printed model again and compare that to the original.
The original, yes.
Okay. What method did you use to rescan it?
We used so we actually used a regular CT scan. I think it was our PET scan. It's not our standard CT scan. It was one of the experimental scanners, but it's not a micro. It wasn't a micro CT scan. So there is potential for error in this right now. There's a scan for this. I think was probably 0.6 millimeter slice.
Okay.
Have to go back and look at the records to be sure. So potentially could match 100%, potentially could match 50%, although visually they're very similar. Yeah, I can't guarantee. We didn't run a whole. That's one bone scan. We didn't run a whole series to sort of measure the error in the system.
Yeah, I was interested in just seeing how was that match calculated.
Basically, my fellow did this, so I'm not sure what he did. I think he put them both into some kind of CAD program and measured free space. But I don't know which. It's probably Autodesk. I guess some measured tools.
And another last question was, what about that percentage? How, like, would that percentage compare, the difference in percentage would compare with what we would see, like, in one old patient animal?
Yeah, actually, if you look at the literature on air cell patency in patients, there's been 7 or 8 papers looking at the volume of air cells. Almost all of them are Korean for some reason, so it's restricted to the Korean population, but it varies from like 2 cubic centimeters, I think, to like 10 or 12 cubic centimeters at the outliers. I may be wrong with these numbers, but it's a quite a huge variation. So an 88% match isn't too bad, even though, like I said, I can't look into the absolute accuracy of that number. It's sort of as good as we can get, short of, I guess we didn't read micro CT printed model instead of running through the standard CT scanner, but I didn't have access to micro CT. I'll get back to you.
For the soft tissue, is the main reason you want to do the virtual reality is because you don't have a good approximation for the soft tissues, right?
The main reason we want to do
The main reason why you're doing the mixed reality is because you don't have a good approximation for the soft tissues.
that's right. And there have been a few attempts at and our attempts as well, building these chimeric models where you spray a layer of something on top of it, call it skin, or you add a dural layer of latex in the back, and you fill the void spaces with, a variety. There's one model from Japan that's got like 14 different substances they're using for the various soft tissue structures. But it's just not it's not an easy way to do it. You basically have to, if you can get me a 3D printer that would print, an enormous range of materials off of the same system, we could maybe produce a 3D printed model that had everything we wanted in it. Almost everything. The other reason that Haptic model is nice is because it's actually a little harder to measure what people are doing with the 3D printed model. Right? You've got a freestanding model. If I want to measure what somebody's doing with surgical tools and so on, I have to add force sensors and position sensors to the tool itself to be done. But it's just not as easy as with a haptic system where I'm actually real-time monitoring and creating those forces and positions myself in recordable machinery.
Okay, that sort of precludes the question. My question was, I've seen in the literature that in the pulp science, there was talking about how, we've got technology now where we can 3D print organs using cultured tissues. Is that something, is there some reason why you couldn't use the actual tissue in your 3D printed model?
I think a lot of those, so the organ printing stuff, and I'm not really up, this kind of different tack that we take, so I'm not super up on this stuff there, but most of the bone stuff is, so they build scaffolds for stem cells and things like that, where the cells infiltrate things. So if that were our take on it, we could conceivably build a scaffold infiltrating with, some bone stem cells, endothelial cells, and whatnot. Like, a Nobel Prize winning kind of thing, but it's would be much harder at that point, and much more expensive to do that than it is for this, which has become the real driver for this is it's cheap to produce 3D printed models, right? You could have done this 25, 30 years ago, as long as you're willing to do it in acrylic or some other plastic. But it would cost you, $500,000 for the machine and $5,000 to $10,000 for the bones. So cost is really a factor in a lot of this stuff.
Time for one quick question.
Very quick question. Have you considered looking at two dual energy CT, try to separate out your components, soft tissue components?
No, I haven't. We haven't.
Well, you could, as long as you can change the KV on your X-ray unit effectively, you'll be able to do that.
Okay.
So we may not have a commercial version of it, but you should be able to do it.
You should just be able to just run it, mount it solidly, and just run the scanner twice.
You want to run it twice, and then you have to do some manipulation to extract the two components. But
We haven't. That would be interesting. I'm going to talk to you further about that because the micro CT works. We get nice resolution, but it still doesn't distinguish soft and hard tissue very well.
and dual energy helps you do that a bit.
Yeah. And then if you throw the statistical pattern matching segmentation algorithm into it, probably more. So yeah, that's a good idea.
Excellent. Well, if everyone could join me again in thanking Dr. Unger. And then two quick things. So the